So next on our list, we are going to hear about some of the Explore presentations. We have Murali Premkumar from Texas Children's. Thank you for joining us.
Good morning. Thank you for inviting me
Our
to
pleasure.
this podcast.
Tell us a little bit about what is the Explore program? What does that look like?
So Explore program is the core group of Children's Hospital Neonatal Consortium executives who have access to this database, and they are able to help with important questions that come up from various subgroups. So I've been working with Dr. Karna Murthy and Dr. Teresa Grover using the Explore projects.
I love that. And you're here to talk to us on behalf of the NEC focus group.
Yes.
On a project reviewing the risk factors for stricture formation following surgical NEC. So tell us a little bit, I guess, some of the background about, why are we worried about stricture formation?
Yeah. So let me first start by saying a few things about necrotizing enterocolitis.
Please.
I know this population does not need any introduction, but it's one of the devastating diseases.
Absolutely.
And this is particularly about the surgical necrotizing enterocolitis, where necrotizing enterocolitis requires surgeries. And we wanted to look at some of the outcomes. So whenever we come up with these projects, we get these questions from the bedside. So when a parent has a baby with surgical necrotizing enterocolitis, they have a lot of fear and anxiety. And this project
Sort of the healthcare professionals, right? Yeah.
Absolutely. And so I think this project is to address some of the questions they have and provide answers to their questions. For example, whenever a baby has a surgical neck, the parents are worried whether the baby will survive. And if the baby survives, will the baby be free from parental nutrition? And if the baby is free from parental nutrition, how long it might take? Will the baby go home on parental nutrition? Not, and what complications could they expect? So these are some of the questions we wanted to address sequentially from this Explore project. And stricture formation is one of the first things which we're looking at. And stricture is a common complication of surgical necrotizing enterocolitis.
So tell us a little bit about your cohort here and what did you find?
Yeah. So we wanted to look at just surgical necrotizing enterocolitis, and we had access to 15-year worth of database from 2010 to 2024. We had about more than 31,000 patient encounters, of which nearly 10,000 were surgical necrotizing enterocolitis. And since we were focused on neck, we excluded those babies with intestinal perforation, abdominal wall defects. And we also excluded those babies who had neck totalis and babies who died within 30 days of their diagnosis of surgical neck. And this was based on the premise that it takes 3 to 6 weeks for the babies to develop strictures. So that's the reason why we excluded neck totalis, and that's within 30 days. And when we made these exclusions, we were left with 2,411 infants. And this is really this is very impressive because most studies which look at stricture in surgical neck are either single center, or even when they're multi-center, they're small number studies. So this is a study which is looking at this large cohort of babies with surgical neck who end up having stricture.
And actually, that's really important as we think about it. Being the clinician receiving this is to really hone in on that denominator, like who gets included, because I appreciate the intentionality of you trying to answer questions for those families whom the baby is not so sick that we think they had neck totalis or die within the first month, but really thinking long term. So what are those long-term complication risks and the risk factors for that risk of stricture in that population? So really narrowing down our population, and yet with the power of CHND, still having numbers and power.
Absolutely. And just to put into perspective, your listeners are very familiar with the NEST trial, which looked at peritoneal drain versus laparotomy. There, the number of infants was 300.
Yeah,
and
you're so right.
Yeah, and the latest STAT trial, which looked at primary anastomosis versus stoma formation, there the number was about 120 to 130. So when we put into perspective, we have this huge database. This is a retrospective study. Still, it has its own strength in harnessing such large number of infants.
Yep.
Amazing. And so it looks like you found the overall incidence of strictures close to 35%. But I thought this graph was so interesting about the risk of strictures, the variability across centers. Um, I wonder what your thoughts are about that.
Yeah, thanks for bringing that up. I know when you initially asked me to talk about this project, I was so focused on the parental questions. I did not address the other objective was to look at the intercenter variabilities. So we also looked at the incidence across 49 centers. There were 49 centers in CHNC. And this graph here shows the adjusted odds ratio across the 49 centers. And as we see here, we go from the lowest risk on the left-hand side of the graph to the highest risk. We also have the dotted line in the middle, which is the CHNC average. The CHNC average was 31%. So 31% of our surgical neck babies developed strictures. So what's impressive is we have centers with risk significantly lower than the CHNC average, as low as 24, and which is higher than the CHNC average, which is 38. So that's a 58% difference between the lowest and the highest risk factors. So this provokes us to think why this could be. It could be because the patient population is different, but we're all level 4 NICUs. So probably that might not be the topmost reason. One of the reasons why we did this was to use this as a benchmark. So then we can look at the practices in centers which have lower incidences and then initiate quality improvement projects to learn from those centers who have these lower risks.
Or even some hypothesis generation exploratory work. Like, what are the factors? We think about, is there a risk factor to the pathophysiology of neck itself that increases? And so maybe there will be some risk of stricture due to the pathophysiology that is sort of separate from care practices. But your inter-center variability data would suggest that care practices around this condition also contribute to the incidence of the strictures, right? And so then maybe some questions to be asked about what is different about those centers. Is it different population? Is it a different type of neck that they're seeing, or are there different care practices?
That's a very important comment. I think the highlights of your comment is, one is this is hypothesis generating because this is a retrospective study, even though it's a large study. And it has both patient variables and institution variables and region variables. We had some bivariate differences in the bivariate analysis, even by the areas within the US. And the ethnicity, Hispanic babies were associated with lower risks of strictures following necrotizing enterocolitis. And even the surgical practices, the peritoneal drain was associated with decreased risk, whereas the stoma formation or those babies who received peritoneal drain and laparotomy, they had higher risk. So I think this underlines your point that there might be patient characteristics, institutional characteristics, and regional characteristics. We don't completely understand the complex pathogenesis of stricture formation, but this is a big step towards trying to elucidate those factors.
I love that. And you were able to identify a number of individual associations. Tell us about some of those.
Yes. So we did this in 2 steps. One, we did the bivariate analysis where we compared the patient variables with the outcome of interest, which was the stricture. And we found several variables which showed the strong associations. We had, if the babies were much older when they were admitted to our level 4 NICUs, and if the babies were of Hispanic origin, then older babies had higher risk. Hispanic babies who were born by a C-section and multiple gestation had lower risks as well. As I previously mentioned, peritoneal drain was associated with a decreased risk, whereas the stoma formation and the peritoneal drain and laparotomy infants had a higher risk. So we then took the variables which had a p-value of less than 0.2 and input them into a multivariable logistic regression model, and that yielded some variables which were still significant. And these were gestation. One is in comparison to infants born less than 24 weeks gestation, babies of older gestation had lower risks. I think this is intuitive. It's the smaller babies are much more commonly to have neck and also to have the severe form of neck. And the delivery by C-section, multiple gestation still remained significant. And what was also interesting was the peritoneal drainage was still associated with lower risk, whereas babies who received stoma had a higher risk. So this was very significant. And when we input these variables into a ROC curve, this was done to yield a predictive model, which was one of the objectives of this project. We had an area under the curve of about 0.67. That is suboptimal, and it failed to yield a discriminative ability. Probably this is because we might have failed to capture some of the unmeasured or unaccounted variables or unknown variables.
Or maybe some of these factors actually are proxying for something else that are more indicative of what really increases your risk, right? So if we think about like the babies that you treat with just a drain versus those who you put a drain in but then still need you to go in.
Yes.
So what is the actual clinical differences between those babies? And if you put that into the model, could your AUC curve become better?
Yes. And I think one of the things we wanted to do going forward is when we made this model, I think we can still make it better by including a few more variables. So one was we had not included the duration of antibiotics in these babies.
And antibiotics in the gut.
So, and also we were unable to include the feeding patterns because it's beyond the limitations of the CHND database. So probably with these extra variables, we might be able to fine tune this model and yield a better predictive model, as you suggested.
Interesting. I wonder now with this information, how is this changing your practice? You spoke a lot about discussions with parents.
Yes, and I think this is just one of the many steps towards addressing the parental questions. So with this, we are trying to address the question from the parents: what complications or how likely is my baby to require another surgery? And we wanted to develop similar predictive models for mortality and whether the babies achieve enteral autonomy prior to discharge and the time taken for establishing full enteral feeds. So with these cumulative predictors, outcomes, we might be able to counsel the parents better in real time. The other strength of this model is this also helps us in assessing the intercenter variability and comparing where we stand in different centers. So I think that's a strength of this model.
100%.
Thank you for presenting this really interesting, I think thought-provoking work. We're always concerned for stricture formation, and it's obvious that some babies are at higher risk than others. What else is the NEC focus group working on?
So we are, as you rightly pointed out, I'm representing the work done by the CHNC NEC focus group. So broadly, we are if we divide this into two categories. One is what projects are we doing utilizing the CHND database, and what are the projects which we're doing using this forum, but not necessarily using the CHND database. So our group has been working on the next step is to look at the babies who receive a primary reanastomosis versus those babies who receive stoma, and looking at the variables and the outcomes to see if one is associated with a better outcome compared to the other. And we also doing surveys. This is an example of harnessing the strength of this focus group, but not necessarily using the database.
Right.
So in the past, we have done surveys on the use of intravenous lipid emulsions, in the surveys on the use of probiotics, and recently we did a survey on the utilization and availability of bowel ultrasound, and that is in necrotizing enterocolitis. That's a manuscript in submission which is being reviewed.
Yeah.
So there's a very concentrated body of great minds in this group. I'm learning every time I meet with this group. So we are trying to harness the strength of that group in doing projects which do not require CHND database to strengthen the collaboration between centers and experts.
Yeah. I love that. And as you said, it's one of the most devastating things that we see. We still don't totally understand even the pathophysiology of neck. So really, really important work to reduce both mortality and morbidity in the NICU for our smallest babies. Thank you for sharing with us.
Thank you for your time and for this conversation. I really enjoyed it.
Absolutely. Thank you.